Sayın hocalarım hoş geldiniz. Omuz Dirsek Cerrahisi Derneği'nin bugünkü webinarında Sayın Prof.Dr. Nobuyuki Yamamoto konuğumuz. Kendisi Japonya Tohoku Üniversitesi'nde, Sendai'de omuz cerrahisi departmanının başında uzun yıllar omuz cerrahisi ve özellikle omuz instabilitesine emek vermiş bir hocamız. Çok kıymetli çok kıymetli çalışmaları var. Özellikle on-tract, off-tract lezyonların tanımlanmasında. Yine çok kıymetli hocamız Eiji Itoi ile birlikte birçok çalışmaya imza atmış bir hocamız. Bugün kendisi bize yeni bir konsepti tanıtacak. Bu on-tract, off-tract lezyonların birazcık daha genişletilmiş hali. Subkritik kemik kaybında ya da periferik kemik kayıplarında nasıl bir yaklaşım var? Onu anlatacak. Thank you very much, Dr. Nobuyuki Yamamoto, to kind acceptation our invitation. It is very important to us to listen your speech because there will be a new concept after on-track lesion. We understand the shoulder instability bone loss, but now we focused on the peripheral bone loss, which is also important, I guess. Please, thank you very much.
Thank you, Anil. First, I'd like to thank the society for giving me this opportunity, and it's my great honor and great pleasure. So I will share my screen.
Hı hı.
Can you see my slide?
Yes, we can see it.
Okay, my city center is located north to Tokyo, 1.5 hour by bullet train, and population is 1 million. From yesterday, we had a snowing already. And my Tokyo University Hospital was built in the 1915, and we have over 1,300 beds, one of the biggest public hospital in Japan. It is well known that large bone loss is a risk factor for recurrence, and the incidence of the glenoid and Hill-Sachs lesions are very high, 86% and 94% respectively. We already reported in a biomechanical study the critical bone loss is 25% of the glenoid virus. So this is a borderline between bone grafting and scopic bone graft repair. In our biomechanical study, we create a defect by 2 millimeter increment. 2 millimeter defect is equal to 8%, 4 millimeter 17%, and 6 millimeter 25%. Less than 17% is safe. We don't need bone grafting. But greater than 25% is risky, so we need to perform the bone grafting. But how about this? The defect between 17% and 25%, it's safe or risky? It was biomechanically gray zone. And I had one question. The 25% is a borderline between bone grafting and scopic bone graft repair, but just below 25%, 24%, can we perform the scopic bone graft repair? I think the many surgeons prefer to perform the bone grafting for this size of the defect. Just below the critical, the bone loss is called subcritical bone loss. This is proposed by the Turkish group. The definition is no dislocation but clinically decrease in QOL. In their study, they investigate the 73 patients who underwent scopic bone graft repair. All subjects are Army, and WOGI score was investigated. And they reported the defect between 13.5% to 20% is a subcritical bone loss. And for this side of the defect, they recommend bone grafting. But in their study, all subjects are Army. So I had a question. How about subcritical bone loss in the normal population? Then we performed this clinical study. 43 shoulder full alignment scopic bungle repair all had a less than 25% glenoid defect, and WODI score was investigated. This is the graph showing the relationship between WODI score and bone loss. There was a positive correlation between them. And bone loss was divided into three. If defect greater than 17%, WODI score decreased significantly. So from our data, the subcritical bone loss was demonstrated to be greater than 17%. And the regarding the WODI score, the less score in male and also less score in contact athlete. So our data shows risk factor are male and contact athlete. For defect greater than 25% bone grafting, but less than 70% scopic bungle repair is fine. But defect between 70% and 25%, which treatment we should perform? I will talk about this later. And we apply the subcritical bone loss to the Hill-Sachs region. We named the peripheral tract region. 83% of glenoid width is borderline between on-tract and off-tract region. But how about this? The Hill-Sachs region located 82%, which is just below the 83%. Can we perform the scopic bungle repair? To answer this question, we performed this clinical study. 50 shoulder who underwent scopic bungle repair all had an on-track lesion, and WODI score was investigated. Our hypothesis, even on-track lesion, the Hill-Sachs lesion located close to the borderline, for example, 80%, their QOL decreased accordingly. The distance from the major margin of the footprint to the major margin of the Hill-Sachs lesion, which is divided by glenoid tract width, which was defined as the Hill-Sachs occupancy in this study. Hill-Sachs occupancy as defined as 100%, which was divided by zone 4, 1 to 4. This 100% is equal to the glenoid tract width. If Hill-Sachs occupancy is greater than 75% located to zone 4, their WODI score decreased significantly compared to other zones. Look at the domain of the WODI score: physical symptom, sport recreational work, lifestyle, and emotion. Among them, physical symptom decrease, and the patient complain difficulty in elevation motion or instability feeling. So 83% is borderline between lump research, lethargy, and scopic bungle repair. This is critical Hill-Sachs lesion. But subcritical bone loss was demonstrated to be 75% from our data. And there was no correlation between WODI score and Hill-Sachs occupancy in our study. Look at 10 patients in zone 4. Their WODI score decreased significantly. And some of them, their WODI score was very low. Here are table of those 10 patients. Look at the sex. 7 out of 10 patients are male, and 7 out of the 10 patients were participate to contact sports. So our data shows risk factor were male and contact athlete. Interestingly, there was no relationship between the body score and the age and the dominance. So even on-track lesion, if Hill-Sachs region located greater than 75% of the glenoid tract width, their WOG score, their QOL decrease, so they need treatment. We named this Hill-Sachs region Peripheral tract region, which is named by Dr. Burkhardt. On the other hand, Hill-Sachs region is located less than 75%. No need for additional treatment. We named this Hill-Sachs region Central tract region. So on-tract region divided into two, central tract region and peripheral tract region, and the borderline is 75%. These days, similar concepts were reported. Near tract region, dislocation to distance, DTD, and HG ratio. DTD is defined as follows. From the medial margin of the Hill-Sachs region to the glenoid tract line. This is DTD. If DTD decrease, the rate of recurrence increase, which is reported by Barrow. And also DTD is less than 8 millimeter. This is predictive failure of the arthroscopic buccal repair. And they named this Hill-Sachs region near tract region. And the lead reported glenoid tract should be viewed as a continuum rather than discrete on-tract region. With the increase of the glenoid defect, WOG score decreased, so there was a correlationship between glenoid defect and WOG score, because in the mid-range, stability is related to the glenoid defect. But in the end range, story is different. We need to consider the both region, Hill-Sachs region and glenoid defect. That's why in our study, there was no correlation between body score and Hill-Sachs occupancy. So the glenoid tract cannot be used as a continuum. So let's compare with the peripheral tract region. For example, in this shoulder, glenoid width is 25 millimeter. So glenoid tract width can be calculated. 25 millimeter times 83%, 21 millimeter. Peripheral tract region width is 25 times 75%, so 19 millimeter. So 21 millimeter is a glenoid tract, 19 millimeter is a peripheral tract line. So DTD is 2 millimeter in this shoulder. So peripheral tract line and the near tract line DTD is here. So if you use a near tract concept, you may overdiagnose. Let's see this case, 21-year male. Glenoid tract line is here, 21 millimeter. Peripheral tract line is 19 millimeter. But near tract line is 8 millimeter here. So if you choose the peripheral tract concept, this Hill-Sachs region is the central tract region. So no need treatment. However, if you choose the near tract concept, the out of near tract, so we need treatment. So we may overestimate if you choose the near tract concept. How about the HG ratio, which is reported by Yang? The definition is Hill-Sachs interval divided by glenoid tract width. So this is that's almost same as the Hill-Sachs occupancy definition. And in their study, HG ratio is greater than 0.7, an increased risk of recurrent instability. HG ratio and Hill-Sachs occupancy definition is almost same. And their value 0.7, our value 75%. It's almost similar. These concept looks very similar, but actually not same. Because HG ratio, the parameter is dislocation, but in our Hill-Sachs occupancy, This is a subcritical bone loss concept. So no dislocation, but QOL decrease. So this is not the same. So finally, so which surgical procedure we should choose? On-tract lesion can be divided into two, central tract lesion and peripheral tract lesion. For central tract lesion, the scopic buccal repair is fine, but for peripheral tract lesion, scopic buccal repair with or without remplissage or latarge procedure. So there are 2 points. First one, we need to consider the glenoid defect first. If defect is less than 17%, small defect, we don't worry about the defect. Just scopic buccal repair is fine. And the defect is very large, greater than 25%, which is a critical bone loss. We should perform the bone grafting, such as the latarge procedure. But the subcritical bone loss, defect between 17% and 25%, we should perform the remplissage or latarge procedure. So which the procedure should be performed? I prefer to perform the latarge procedure because the first and these days mid-range injury is more common than we expected. Dislocation occur with the arm in the mid-range. And also, the biomechanical study demonstrated stability does not increase in the mid-range even after scopic buccal repair. So let's see the study, previous studies. Lamprey's contribute to stability in the mid-range. Biomechanically, there are many studies investigating the effect of the lamprey on stability. But no study demonstrated the effect of the lump research on stability in the mid-range. Only one study by Schrader. They investigate the effect with the arm in the 0 degrees and 45 degrees of abduction. And they conclude no effect on the stability. How about clinical study? Unfortunately, no evidence so far. So look at the data of the latarge procedure. We already demonstrated the main stabilizing mechanism of the latarge procedure is a sling effect provided by conjoint tendon and the subscapularis. The contribution of the sling effect to the stability was 80% in the end range and 50 to 60% in the mid range. And in the mid range, with the increase of the load to the conjoint and subscapularis, the stability also increase. So latarge procedure contribute to the stability in the mid-range. That's why I prefer to perform the latarge procedure for the subcritical bone loss. So second point is we need to consider the risk factors. Our data indicated risk factors are male and contact athlete. So if patient has a peripheral tract lesion, he is young male with high activity and participate in contact athlete, so he has a high risk. So for this patient, we should perform the latarge procedure. However, the patient who has a peripheral tract lesion, the female with low activity, non-contact athlete, this is a low risk. So we can perform the scopic buccal repair. But we are not treating the bone loss. We are treating the patient. And many factors are related to the patient. For example, age, the sex, dominance, type of sport, contact or non-contact, sports level, activity level, and job, and combined region. Among the Lakshi, and among them, our data demonstrated age, sex, and activity level, contact or non-contact athlete, but we need further study to clarify this. In summary, we should consider subcritical bone loss when treating the patient with anterior instability. Subclinical bone loss is still a gray zone in terms of the surgical treatment. A new concept of the peripheral tract lesion is introduced in this presentation. We should consider the granular bone loss and the risk factor when thinking about the peripheral tract lesion. And near tract lesion, if you use this concept, you may overdiagnose. HG ratio and Hugh-Sachs occupancy is not the same parameter. And the treatment strategy for subclinical bone loss was explained in this presentation. Thank you for your attention.
Thank you very much, Dr. Yamamoto.
Thank you.
This nice presentation. And now we have questions. I have questions
Mm-hmm.
first. Then we ask the audience for any contribution or question. When we make decision about the treatment of after shoulder dislocation,
Mm-hmm.
we discuss about the bone loss mainly, but
Mm-hmm.
sometimes the age and sex and dominance, also
Mm-hmm.
soft tissue
Oh,
injuries,
yes.
also
Yeah.
concomitant. What is
Yes.
your opinion about the specific soft tissue injuries, and what is your treatment modalities in relation with these soft tissue injuries?
Yeah, that's also the very important. Always when you think about soft tissue and bone loss, but about the soft tissue, if the capsule is very much thin and very much weak, fragile, in that case, uh, ca- bunker repair is not good option. So in that case, we should perform the lateral procedure, but that is not so the common. Probably the revision surgery or very much, difficult case, sometimes encounter, but it's not so common. And also, we need to consider the laxity, joint laxity. If the patient has a joint laxity, we need to reduce the laxity, like capsule application or the rotator interval closure. And also, lump size is one of the option in that case. So always we should think about soft tissue and bony problem at the
Uh,
same time.
uh, how about your opinion, like ALPSA or Hugel lesion in concomitant with the shoulder dislocation? Do you consider the arthroscopic Bankart remplissage or Latarjet?
For the ALPSA lesion, I perform the scopic, ALPSA repair, bunkal repair, and for Hagel lesion also scopic repair. That's possible.
Mhm, mhm. All right. Thank you. We got one question
Mm,
from Batuhan Yürük. What
mm,
is the best method to measure the His-Sachs width? It is difficult to measure a three-dimensional defect. One.
mm, mm.
The second one, have we completely abandoned His-Sachs depth or volume? Is it only width what is important now?
Yeah, first question, we recommend when we evaluate the Hill-Sachs lesion, we recommend the 3D CT, 3D dimensional reconstruction image. If you use a axial image or MRI image, you may overdiagnose the off-track lesion. We already reported this. So, if possible, three-dimensional image first, then you can draw a line of the glenoid tract. Then you can pre, draw a line of the glenoid tract precisely. And the second question is the most important factor of the Hugh-Sachs lesion is the location of the Hugh-Sachs lesion, not width and the depth. Even the Hugh-Sachs lesion has a very deep and very long, but it's located laterally. There is no chance of the engagement. But even it's the very shallow and the very small Hugh-Sachs lesion, it's located medially. There is a chance of the engagement. So most important factor is the location of the Hugh-Sachs lesion. It's already reported.
Okay. And I have another question.
Mhm.
What about your opinion about the micro instability?
Mm,
We sometimes we decide for the arthroscopic Bankart repair or remplissage, specifically the sports guy with subcritical bone loss. Yes, there will be no redislocation, but some kind of pain, some kind of range of motion restriction can be occur. It is mostly comes from the micro instability, not through
mm,
dislocation, but micro
mm,
instability. Do you think that the lethargy is much better to cut out the micro instability, or maybe sometimes the
mm.
technical deficiencies about the article Bankart and remplissage?
Yeah, and I don't have a clear evidence, but my impression is lateral better because after lateral procedure, a little bit, range of motion restriction occur compared to scopic bunker repair. And in those cases, the patient with a micro instability, we could not control the laxity of the patient. In that case, the patient has a micro instability. So we need to control the laxity. But sometimes it's not easy to control. The too much application, sometimes it may occur the restriction of the range of motion. But if we preserve the capsule, the laxity still remained, micro instability occur. But in those patients, latargy is better because after latar procedure, range of motion restriction occur compared to scopic bunker repair.
All right, thank you. And also, what is your opinion about the future? Do you think that is it enough now? Now we start with the on-track, off-track lesion. Yes, we okay. But now we additional the central tract, the peripheral tract lesion. What is next? Do you think that some new concept is in the future?
Yeah, it's not completed yet. Of course, there are many, factors related to the patient, as I told during my presentation. The laxity, especially the joint laxity, also very difficult problem because your glenoid tract virus and my glenoid tract virus is different because range of motion is different. So now our concept is not including the joint laxity or range of motion. So now still, we have some ongoing study to clarify it. So we have a lot of homework to answer your question.
All right. We got another question from Cemil Cihat Gedik.
Mm,
Thank you for this great talk. What do you
mm,
think about the DAS procedure, transferring the biceps to the glenoid?
mm.
What is your
Uh,
opinion?
yeah, that may be one of the option, but I don't know, the exact biomechanical effect. But yeah, some guy reported, but still we need to clarify its really effect to the stability. Especially, I'm interested in the mid-range stability. These days, dislocation is related to the mid-range rather than the end-range motion. So I'm interested in the effect of this procedure in the mid-range.
Mm, mm. Right. Any other question? I guess no. İlker, Dr. İlker, maybe question or contribution. Do you want to?
Thank you. I would like to ask your approach to overhead athletes. Do you change your practice in basketball players, handball players who threw at overhead level?
Yeah, yeah. Actually, the throwing athlete after bunker repair is a little bit difficult. 5 years ago, we reviewed our case series, and the restriction of motion is occurred, and then return to sport, is a little bit lower than we expected. Then we change our uh, rehabilitation protocol and accelerate our rehabilitation protocol. And also during surgery, when the past the suture of the superior portion of the IGHL, so we tie the IGHL in this abduction and external rotation position to avoid the restriction of the external rotation. that is our, another the tip for string athlete. Another one is the rehabilitation protocol change, more accelerate. Yeah. U- Usually 3 weeks immobilization after bunkle repair, but in the throwing athlete, soon after the surgery, the passive range of motion exercise start. That is
Right.
our treatment strategy for throwing athlete.
Do you use the Latarjet procedure, the overhead and throwing athletes?
No, because from our data, around 10 degrees in abduction external rotation restriction occur. So for throwing athletes, especially baseball player, it's not good. In
Hmm.
those cases, we do the bunkle repair with lamp massage.
Right. Well, thank you very much for your good contribution. If it
Thank
is
you.
no question anymore, we can finish it now. Thank you
Thank you
for
very
your nice
much.
acceptance. We appreciate it. See you next meeting. See you in
Okay.
Korea, in Japan, and elsewhere.
Okay.
Thank
Okay.
you.
See you. Thank you very much.
Bye
Goodbye.
bye.
Bye.
Katıldığınız için hepinize çok teşekkür ediyoruz. Hocamıza da çok teşekkür ediyoruz. Kıymetli bilgiler bizlerle paylaştı. Bir sonraki webinarda tekrar görüşmek üzere. Herkese iyi günler.